the sinus. 6 area it is way down, even in 5 area it is closer. Maybe 4 area, various things, right? 4 area above the external root bone is there. This is the mesomaxill buttress area. So we are getting good bone over here. But here, if you see, the sinus is invading through the mesomaxill buttress area, right? This is probably the canine tip, right? This is the 4. So the 4 is not great. 5 is gone, right? So almost like it is similar on both sides. Here the 5 is not favorable, close to sinus. Here also the tentative, even though it is edgeless, in imagination you see the 5, the sinus is closer. 4 is somewhat okay, but you have to tilt it easily. See the sinus, no? It occupied the entire space. Right? So you buy land, if you don't buy house, no, the other people occupying. The same way the sinus is occupying from here to here, full stretch. Since some tooth is there, it is not occupying the here. But here the entire nasomaxill buttress is occupying. Even the pterygoid is gone on the right side. Right? Here, since the 8 is present, the sinus is respecting, it is not pneumatizing. But here, since the 8 is not present, it is going. So the tentative plan will be placing 2 pterygoids and 2 implants in 1 and 2 region, and 2 implants in the we engage the nasomaxillary buttress. From where we are angulating only we change. And here we may angulate from premolar to nasomaxillary buttress. Here we may come till the canine first premolar. From where we are starting, it may be different, but where we are ending, it will be in the nasomaxillary buttress. So totally 6 implants. So all on 6 planning. First we'll plan the left pterygoid. Left pterygoid is the key implant because nowhere here you cannot place any implant. The distal implant will be the first premolar implant. From first premolar you cannot give of second premolar and first molar. Definitely you need a canine. So the most important implant in this patient is the left pterygoid. First you have to finish that implant, right? See the maxillary sinus has come to here. Okay. So if you start drilling and if you go like this, you will enter the sinus. Right? If you go like this, you will get less bone. So exactly you have to go in this direction. Right? Very thin bone will be a challenge. So the buccal cross section view. From buccal to palatally you are tilting it. If you go like this, you will come buccally. Perfect the lateral pterygoid. You will see the 360 degree. Okay. You see here some part is inside the sinus that we cannot avoid. Okay. You see the 360 degree. This is the panoramic view or IOPA view. If you take a IOPA, you will see like that. If you see here, this is the greater platin foramen. Can you follow that? Slowly it will go and wedge here, right? If you tilt too much here, you will enter the greater platin foramen and into the nasal cavity. Okay. So the key point is starting point where we are starting here. Okay. If you start too much anteriorly, you will definitely enter the sinus. So just in front of the notch. Okay. And not too horizontally and not too vertically. In between, almost it is like 45 degree, right? 45 or 50 degree. And buccolingually, Buccal buccal pressure you have to tilt palate. Okay. So 4.2 into 16 or 18 or wherever you are feeling the resistance drop. Okay. You can select even 3.75 because crustally also there is bone resorption because of long-term potential resistance. Buccally you are not getting the great effect. So 16 or 18 length diameter is 4.2 or 3.75 you will be using violin now, right? Now we will see the right pterygoid. So even before we do the extraction, we just remove this very much mobile 2 1 2 2 3 2 1 2 3 extraction and finish the pterygoid first. Okay, that will be a better idea because if you do extraction of these two, bleeding will be coming. So better if you finish the pterygoid first. And after extraction, you have to do even before you do incision and flap elevation and areoleplasty, better finish the right pterygoid. Okay. So whenever possible, finish the pterygoid. Okay. So this is a IOPA view. If you go along the socket, if you entering the sinus, this is the 8, right? So from the crest of the 8 socket, we can slightly angulate it distally. You are into the good bone. Here, somewhat it is okay because the sinus is not coming to here. So here it is in good bone, right? The only thing you have to angulate it very much easily. Compared to left side, you have to tilt it very much easily. What is the reason? Because here the teeth is present. If some resorption has happened, this entire crest will move upward. So you don't have to tilt very much palate. Right? This is enough. Okay. It's in 360 degree. It is in good bone. Almost 4.2 we can select because in the immediate extraction we can select 4.2, 16 or 18 depending upon where that will drop your feeling. So we can see the what is the distal angulation, how much distal angulation we can see this one out. This is almost 40 degrees. So two angulation, mesodistal angulation and buccal angulation. You can see the sinus is touching here. Here the sinus is invading the our implant. Now we are planning for anterior implants. 1 to 1. So here we are getting another channel, that is a mesodense is here. Okay, can you see? Here the mesodense is here. The two inverted. You will see the mesodense first. With analysis. Yeah, you can see. This is the inverted mesodense. It is the crown is towards the nasal floor. The root is occupying the entire alveolus. The moment you remove this, there is no bone left in this area, right? So what is the location? It is exactly almost in the midline and little bit into the two-one area. Okay. See exactly in the midline area there is a mesodense. It's cramping. So we can see the mesodens is here. But the thing is, if you closely see the mesodens, there is no periodontal space. It is fused with the bone. There is no pulp space. So there is no need to remove it. We just try to avoid it. Even if our implant touches this, it is not a problem. Okay. Now we'll plan for the 2-1, 2-2 area. Okay. Very resorbed bone. See the bone with this only. The bone with this only. The bone with this only 4.1 in the crest. Okay, so if you place a 3.75 or 3.8 implant, the remaining 0.5 mm bone will be on this side and this side, and they will reserve and will create problem. So what we do is we do the palatal approach, so that 3 mm bone will be on the lateral side. Palatally it will be protected by this palatal soft tissue to be like the mother. This bone will be like the father. They will protect this implant child. Okay. So better to select a smaller diameter, 3.75. Okay, already less bone. Why to select a bigger bone? So completely palatal approach, or we can place a BCS. Simpler. So no need to do any other plastic here. Already resolved. 11.5 is good, right? 11.5, 3.75, 11.5 we can place. Definitely this implant may slightly touch the, this is the mesodens. That is good for us actually. So we'll see the 3D different. Okay. See the mesodens is visible through the crest. We can even see the mesodens. We do small bone smoothing, and we can do our drilling just related to it. Okay. So now we are planning for the right side. 1, 1, 1, 2. Here also it is resolved, right? The ridge is only 2 mm, right? So 3.75 into 10 or 11.5 we can place. Right? Yeah, here also. If you see the mesodens, the crown part is resolved. The inside of crown part is resolved. This usually happens. Internal resorption. So 2 implants we can place with good stability. Here conventional implant is very challenging. Even conventional implant they are doing palatal approach, no? Same way. So these threads will be exposed and they will be covered by the palatal tissue. It's a good tissue. Now we are trying for the mesomaxillary buttress. We will see the canine now. Okay, this is the canine area, right? Exactly in the canine area. But the thing is, we are placing the anterior implant almost in the 2-2 area. So if you place implant in 2-3 area, the implant will be little close. You will see. Okay, this is the 2-3 area. So if you extract and if you drill crustally, the labial bone will be very thin, palatal bone will be very thin. So better place the here also palatal approach. But the thing is, where you are starting is not from canine, from premolar. Just distal to the canine, you will check. But the moment you go distal to canine, there is lot of resorption. No? So, distal to canine, we can start straight drilling, axial drilling. We will enter the sinus. Now we will enter the sinus. So slight mesial tilt. Slight mesial tilt. After that also palatal approach. 13 mm, right? Here we are not going by any abdominoplasty. So 13 mm, 3.75 mm, very minimal diameter, very less bone. Okay. What we can do is we can just slightly tilt this here slightly here. We'll see what it is. So that we can reduce the inter-implant distance. Okay. But it will create problem, in framework fitting and all. Since it is only 6 implant, that is not a big issue. Are we getting any great advantage, in slightly distal fitting? Not that much. Since we are using titanium bar, it will take care of everything. It will take care of the rigidity. So we will start the drilling from 2 4, and it will be like almost like a straight implant. Mild mesial tilting, that's it. So you will understand this in the 3D different image. Here it is engaging this zygomatic buttress. This is the sinus. This is the small buttress. So it is a very ideal place to engage the implant. Through this buttress, forces are very favorably distributed towards the skull. So the patient is biting and the force is coming along the implant and it is transmitted through this small buttress. So it's very ideal for the patient. So here the buttress is here. Now you will see the implant. The buttress is labially, it is like this. Anteriorly it is bordered by the nasal cavity. Behind it is bordered by the sinus extension. Okay. So it's a 3 pyramid shape. Right? Buckling by the buccal bone. Okay. Easily by the nasal cavity. Distally by the sinus. So the more the sinus is back, the more it is good for the operator. Okay. The nasal cavity it won't enlarge. That is a good thing. Okay. Right? The nasal cavity is constant. But the only thing is the sinus is the variable. So right side, X-ray is showing very dark. Now it's right. Now we are planning for the right side. So here there is no need to come till mesomaxillary buttress also. And here the sinus comes, right? Okay. So from 5 it is not at all favorable, right? From 5 if you tilt also, it's not good. There is a lot of bone loss in 5. Crustally there is a lot of bone loss in 5, so we are avoiding 5 and we are 4, right? We are in the sinus. We will tilt slightly inside. Now we are in good mode, right? That is almost in the buttress area. Right? So this is the buttress region, right? We can place the implant like this, or we can place the implant like this from parallel crest. So around almost like 13 mm or 16 mm implant we can place. We will try from canning. From premolar place. From first premolar. This is very good. We'll see what they do. Here also we can try parallel approach or from the parallel crest we can try. So the final conclusion is 2 pterygoid, 2 anteriors, both parallel approach. one implant will be touching the resorbed. Here from the fovea, very mild initial tilting. It is better to expose the nasomaxillary buttress and it can target the area. Right side also slightly similar. Since the sinus expansion is less here, we can just place the implant just distal to the nasomaxillary buttress. Here the available buttress area is more compared to the left side. See here the buttress is available from here to here. You have the freedom, okay, to tilt the implant, to engage the implant here or here or here. But here the freedom, there is no such freedom. The sinus is expanded. The buttress area is reduced. So 1, 2, 3, 4, 5, 6, total 6 implants. You just check the 6 area. You will see. Sort of curiosity. No, it's not very good. Maybe easy lock 6 on bonus, but it sound. Actually, this is 6. This is 7 or 8. We don't know. Maybe the 7 was extracted long back. The 8 has forward. Okay. So we replan the 8. Start cleaning from here also. Okay, this is also from the crest. You avoid the socket and you start the cleaning from crest. So you will be getting more straight angulation. No? So the target angulation will be much better. If you start from here, it will be more easily treated. Right? So design is quite challenging. So if you start the drilling from the crest, slightly distal to 7. Sorry, the easily migrated 8. Almost the angulation will be much better. You can get in much better.